I'd like to welcome Dr. Jay Reynolds, who we're lucky to have as one of our geriatricians in county, old elder care kind of specialists. And Jay's going to talk to us about delirium. Previously kind of called acute confusion, but we like to call it by its proper name. And I don't think he needs any introduction because I know he's going to introduce himself. But I'm really grateful that Jay's come to talk to us today because we really want to raise awareness about this condition, and it's for everybody to kind of know about. We know that people living with dementia are more at risk of developing delirium. With no further ado, I'll hand over to Jay.
Hello. My name's Dr. Jay Reynolds. I go by Jay. In the hospital, nobody calls me Dr. Reynolds. So I get told off always for being too friendly with people, but it's just me. I'm a geriatrician, care the elderly consultant. I've been called many things. I started life as a US Marine Corps Marine. So I was born in London, grew up in Oklahoma, joined US Marine Corps, came back here following a young lady, joined the Royal Marines. Gulf War, I got severely injured, so the military trained me as a barrister at law. So you have me to blame for the Millennium Dome, for the London BAI. Crumbs. I set up the 3 network. I used to work for the police, and then had a disagreement with the consultant at Derriford, and he said, if you think you're smart, become a doctor, so I did. And I went back to work for him a couple of years later, and he didn't remember me. That was good. So I'm the clinical lead for dementia and delirium at Royal Cornwall. They headhunted me out of North Devon, where I'd been the lead there. Actually, I was the lead. I was the only one. So I could say I was the lead. It was just me. But they headhunted me out of Wales because they had some problems with dementia and delirium. And delirium is one of my passions because it's done very, very badly. I'm going to put my hand up. I wrote a whole presentation a couple of weeks ago, which Paul badgered me for weeks and weeks and weeks. And I was going to do prescribing in delirium. And then the enemy at home said to me, is everybody going to be a prescriber? And she told me this last night about 8 o'clock. So I rewrote a new PowerPoint at 8 o'clock last night. And I finished it at 6 o'clock this morning. And then I left at 6 to get here because I don't live in Cornwall. So I was going to just talk about, look at delirium. So what it is, what it's not, the different types, risk factors, the easy spot, assessment, treatment, ongoing issues, and quality improvement that I'm trying to get done. So understanding delirium. So acute cognitive disturbance. So there's a nice pat phrase, delirium is characterized by sudden changes in consciousness and thinking, developing quickly and fluctuating throughout the day. Personally, I prefer delirium usually occurs when a vulnerable brain plus an acute insult interact. So that's my preferred version. Okay, and this, you'll see what I'm about, right? What it's not. These are things I hate from my clinicians. Now, some of my clinicians are here. They're sat on that table. So I've managed to bring them up, and I've got one of my colleagues, who's another consultant, in the back, so she's going to give me bad feedback, I know. So I hate the term off legs. Okay, so if you're a clinician and you use the word off legs, stop. Because it's a misdiagnosis. If you label somebody as off legs coming into the GP practice, into your nurse setting, you label off legs coming into the hospital, one, you're not going to get paid because the coding department only looks for the word delirium. If you write off legs, I used to say to doctors in court, what does that mean? And I'd then give them a medical textbook. And I'd say to them, show me where off legs is a diagnosis. And they wouldn't be able to. I see off legs for poor mobility, for functional decline, for confusion, for dementia, for delirium, for chest infection, for infections of the legs. I see it for everything. And I go back and I say to the clinicians, I challenge them, what does off legs mean? What are we treating off legs with? So don't use word off legs. Neither is it muddled. These people are not muddled. I'm muddled. I'm nervous right now. I have an anxiety diagnosis. So I'm panicking, so I'm going to get muddled. But people with delirium and dementia are not muddled. It's not acute on chronic confusion. That's what we used to call it. It's not pleasantly confused. I hate that term. So that must mean if you have one definition, the opposite definition means nastily confused. And that's a legal maxim. If you state one thing like this, someone must be pleasant, therefore, ergo, somebody must be unpleasant. And that's not right. And it's also not senile dementia, which I see not so often now. And I think that if you listen to the doctor, and the doctor describes to another doctor or to his colleague any of these, your loved one's been misdiagnosed. Because these aren't diagnoses. These are opinions, in my opinion. So, core clinical features of delirium, okay? And I'm going to get on a bit more about delirium as well, but reduced attention, these people are easily distracted, or they cannot maintain, or they shift their focus too easily. They have altered awareness, reduced orientation to their surroundings. So they might not know who you are, where they are, what time it is. Cognitive disturbance, so they might not be able to remember things that you'd expect them to remember, the name of the dog, the name of you, or who you are. Disorganized thinking, they can't do things sequentially, things that you'd expect them to do. You know, Mum normally does her own banking, but she couldn't do it. Mum would normally go and buy a full shop, and she's just come back with a carton of eggs. You know, language disturbance, not being clear. The fluctuating course, often worse at night, when things are quiet. In the medical world, we call that sundowning. People tend to get more agitated as the evening comes on. And also in hospital, you know, night times in hospital are loud, noisy, and bright experiences, which are not good for people with any form of confusion. And delirium is acute onset. It's rapid change to baseline, rapid change to their mental status. But why does it matter? Well, it's actually a clinical emergency. Nationally, delirium is classed as a clinical emergency. And it should reflect the fact there's an acute physiological stress and or illness upon that person. But this is where it gets scary. So delirium, which most people with dementia will develop, increases mortality. Latest research suggests 78.8% increase in mortality. It's increased falls, which means they come into hospital, which makes delirium worse. Long hospital stays. So if we block the back door of the hospital where people can come out, we block the front door. So we get ambulances sat at the front of the hospital waiting to come in because there's no beds, because people are staying longer in hospital. That's also had a cost function as well, a cost element on the hospital. So if you think it's £1,000 per day, someone stays an extra 3 weeks in the hospital, and that's one patient. And you'll see some figures in a minute which might open people's eyes a bit. Increased cognitive decline. So if you have somebody with a cognitive impairment and they have delirium, their impairment will get worse. It may not recover. And a higher risk of later dementia. So if you do not have dementia yet, and you actually experience delirium, you have a 30% increased chance of developing a dementia as life goes on. So that's quite serious again. There are 3 types of delirium. The clinicians will recognise 3, but maybe there's 4. So the first type I talk about is hyperactive delirium. This is the patient who's very agitated, they're restless, they tend to hallucinate, they become aggressive, and they may become violent. Not always, but they may. The second type is the hypoactive delirium. So this is a patient who is drowsy, asleep all the time. This is what they like to call pleasantly muddled or pleasantly confused. Okay, drowsy, withdrawn, reduced movement, most often clinically missed. So this is the patient who's the quiet one in the emergency department, the quiet one on the acute medical unit. Everyone says, oh, they're lovely, because they're no hassle, they're no bother. Then we have fluctuating delirium. So this is where the patient has both the first two, both 1 and 2. And typically, if you've come in and you've been hyperactive, you then fall into the second one and you become hypoactive. But not always. You can be hypo and become hyper. And then the last one is the one that medics are very hard at recognising, and my psychiatry colleagues are better at recognising, which is pseudo-delirium, which is psychiatric conditions that basically closely resemble delirium. And we do get quite a few of these patients as well, where we think they've got hyperactive delirium, but they might have severe depression or psychosis or some other condition. This is my little grid, which makes it a bit easier for me to explain to junior doctors the difference between delirium, dementia, and depression. You'll see at the top. And then down the side, we get a few of the little diagnoses that they might actually see, and you can see the difference then. So delirium is normally rapid, whereas dementia is normally gradual, but of course people have to start with the dementia, so it might be a very quick ingress into the dementia. But most people, when we have a diagnosis, have had dementia for at least 3 years before they get their formal diagnosis. And then depression is gradual. So I talk about the 3 Ds, depression, dementia, and delirium, because they all have very similarities, but they just have different ways of presenting. And this is what can make it very difficult for young doctors in the emergency department and on AMU to actually spot deliriums versus depressions versus dementias, especially if we have a patient who can't give us a history. Then it becomes even more of a investigative thing that we have to sort of dig into. So these are the things we can't change. Predisposing factors. What makes patients and family members more vulnerable? So advancing age, well, we can't stop that, and especially over the age of 65. Cognitive impairment, very strong risk factor for delirium. Previous delirium increases the chances by another 30% of having another delirium. Chronic illnesses, multiple comorbidities. So comorbidities are other illnesses that you carry as normal. It's your past medical history. Sensory impairment, so being blind, being hard of hearing, massively increases your chance of delirium, and also your chance of developing another form of cognitive impairment called Charles-Bonnet syndrome. Then we move on to things like functional dependence and immobility. So if somebody has functional decline, they're more likely to get delirium. Malnutrition and dehydration. We know with dementia patients, they forget to eat and drink. This makes delirium much more worse. And then alcohol misuse, which we see predominantly in probably about 5% of our patients that I see quite often have alcohol misuse. Precipitating factors, so these are the things that can trigger delirium. So you've got your past medical history, but now these are the things that are likely to bring the delirium on. So infections, and that's any infection. The three I've put up there, the first two are our most common ones, UTIs and pneumonias, or lower respiratory tract infections. Sepsis of any cause, and sometimes in 30% we never find the cause of the infection. So 30% of all infections we don't know what they are. So we treat as we think we find. Medications. Certain medications cause delirium, so strong painkillers. I'm not going to go too deeply into these, but sedatives and antipsychotics, something called polypharmacy. Now, I've worked extensively in the southwest, London, east of the country, Wales, so I've been all over. And every hospital has a different idea of what polypharmacy is. But roughly speaking, if you're on 6 drugs or more, you're taking too many drugs. Because at that point, you're taking drugs to counter the effect of other drugs that you're already taking. And that puts you at risk of delirium. Changing drugs, increasing or decreasing doses of drugs, and withholding drugs causes delirium. So you're starting to see the picture of how complex this becomes. Metabolic disturbances. Things like too high salt, too low salt in your blood. Same with the sugars. There's lots and lots of blood tests that this can affect. Potassium, there's lots of things. This is just to give you an idea. Sugar imbalances, diabetes, hyperosmolar non-ketotic states. It's a fancy way of saying a really sort of emergency of sugar balances, same with DKA, diabetic ketone acidosis. So people that have diabetes are at greater risk. Renal disease and hepatic disease, so disease of the kidneys and the liver, expose you to delirium even more. And then lack of oxygen, pain is a big one. Chronic versus acute pain, pre-op, post-op pain, broken bones, osteoarthritis, rheumatoid arthritis, gout and pseudo-gout. These cause pain. These can also cause delirium. Head injuries, especially from falls. Back injuries with chronic pain. These things can cause delirium. Surgery and anesthesia, so people obviously needing emergency surgery, but also things like hip fractures and cardiac surgery are leading causes of delirium. Sleep deprivation, if you think about the dementia patient that flips from night to daytime, so they're up all night trying to sleep during the day, people wake them up. In hospital, we tend to keep the lights on for long periods of time. Nurses at night and doctors at night talk loudly, especially people like me. We walk in and out, we talk quite loudly and wake people up. Restraints and catheters. Okay, a catheter is restraining someone to a bed. So these things cause delirium and withdrawal states. So when people stop drinking alcohol, ETOH is alcohol, and if they stop taking drugs, and I don't just mean prescribed drugs, but also drugs that we probably shouldn't take. So we teach the junior doctors and other people in the hospital to try and think their way through it. We call them sieves, basically, like a surgical sieve or a medical sieve. So this is the one that Royal Cornwall uses, called Pinch Me. They actually use one called Pinch Me Sue. I've never learnt the Sue part because nationally everyone uses Pinch Me. So it stands for pain, infection, nutrition, constipation, hydration, medication, and changed environment. If you think a patient who comes in with a fall and a head injury, maybe a broken hip, they have pain. They may well have, send me a sign. They may well have an infection that made them fall, a UTI or a chest infection. They're normally not eating very well. They're normally then also not drinking very well. If it's a urine infection, they may well be retaining urine, which has been caused secondary by constipation. We give them lots of medications when they come in. We give them painkillers, we give them antibiotics, and we change their environment. They've been picked up by an ambulance, they've gone to the emergency department, they've gone into the acute medical unit, they then get moved at 4 o'clock in the morning to another ward, and all of these things on their own cause delirium. But I often get my junior doctors to look and count how many causes there are, and then you ask them, why do you think they have delirium? This is another one that spells out delirium. We don't use it, but people around Wales and that tend to use this one as well. It's exactly the same as Pinch Me, but it's a bit longer, that's all. So when people come to hospital, the government says that we need to assess them. So we have to do an assessment and a diagnosis within 24 hours of coming to the hospital. That's how the hospital is going to get paid for a delirium. So all hospitals tend to use 480. And the purpose for that is it's rapid screening. It has 4 components, that's why the 4. So alertness, abbreviated mental test, attention, and acute change. Typically takes about 2 minutes. It's 91% and 81% specific and sensitive. So basically that just means it's very good at picking things up. And if you score greater than 4, you've likely got a delirium. And most people that have a delirium score 12. If you score between 1 and 3, you've likely got cognitive impairment, but only likely. And if you score 0, it's unlikely to be a delirium. Well, how common is delirium? This is where it gets really scary to me. So Royal Cornwall has 750 beds. So at any point, there are roughly 225 patients on our wards with delirium. Cornwall Foundation Trust has 10, I'm not an expert on Cornwall Foundation, I had to Google this last night. They have 10 hospitals, so they have about 300 beds. So they all have about 90 patients, okay? So, and then we think, how many patients come through the door at Royal Cornwall that we have to test that are over 65? So I've got a colleague here, Steph, that does all my nomenclature. Steph, wave for me. She does everything to do with dementia and delirium and falls. She's amazing. So she works with me very closely. She's a guru in all this. Every month we chart about 5,000 patients coming through our hospital that hit our criteria for assessment for delirium. Okay, that means 1,500 patients coming through the door with delirium, of the 5,000 that actually pitch up at the front door. And that's scary numbers. That's absolutely scary numbers. And if I go back and say our pickup rate is about 1%. So if I said to you, you're only getting picked up 1% out of everybody that comes through the door, that's numbers that are nationally available. Okay, so most hospitals have a delirium population of 25%, but in the southwest it's 30% because we have an more aging population down here. So if you think of 30% and we're only picking up 1%, that's scary numbers, because that means there are a lot of people that aren't getting picked up. So treatment. Well, the treatment for delirium are vast. First, treat the underlying cause. So if they've got an infection, treat the infection. If they've got a fracture, treat the fracture. Okay. If they've got a salt problem, treat the salt problem. If they've got a sugar problem, treat the sugar problem. It's not hard, really, I don't think. But you also have to provide support for other things as well. And we should do non-pharmacological care. So we shouldn't go straight for drugs. So if a patient is confused, you shouldn't give them antipsychotics straight away. If they're aggressive, we should try and de-escalate them in other ways. Most patients have more than one cause, like I just said, and some of them have all of them, and that's that pinch me we just went through. Treatment focuses on reversing the trigger and protecting the brain. That's the most important thing. You want the brain to come up and get back to its normal working ability as it was. So type of treatments, again, it's quite vast. Not every patient gets all of these, but antibiotics, fluids, correcting blood derangement, catheters, laxatives, analgesia, stopping culprit drugs, managing withdrawal of alcohol or illicit drugs. We use calm communication, repeated orientation. So if there are clocks visible, you make sure they've got the right time. Okay, if you ask them what the time is and they don't know, give it to them. Orientate them continually, let them know you're in hospital. This is your daughter, I'm your doctor. So we do it constantly. We always encourage family presence. So on the dementia and in the wards that cover delirium, we always want families around. It's great to have families there. If they have visual problems, make sure they have their glasses. That's the one great thing you can do for your loved ones. Make sure they've got the glasses. If, like me, they have hearing aids, make sure they have the hearing aids and batteries. We do keep some batteries, but not all of them. And it's very frustrating when we don't have the right batteries and the patients can't hear us. We try and improve their sleep. We make sure lights are off on the wards that manage dementia and delirium. We make sure the lights are off. We try and ask us, there's signs up now, finally, that says be quiet at night. Don't walk around talking about what's on TV. Try and be quiet. So we can improve their sleep. There is a policy now not to move people after 8 p.m. at night. Unfortunately, Steph and I look at all the data that shows that it's still very commonly done. So patients with dementia and delirium are moved at 2 o'clock in the morning to fill beds up. And we fight against this all the time. And then also having physiotherapy and occupational therapy. If there are any here, I'm sorry, I call you physio-terrorists and occupational terrorists because you frighten people into getting better. Medication, again, not first line. So when we're looking at people, they become severely distressed, they can become violent and aggressive. If they become a risk to themselves or risk to others, or they are preventing essential tests and treatments, then unfortunately we do have to resort to using normally antipsychotics to try and calm and sort of take that stress away, maybe get the important CT head or the MRI brain done to try and see what we can treat, try and help that patient as best we can. Historically, we've always used lorazepam and diazepam. These cause delirium. Ironic, isn't it? Haloperidol is a drug that came out before I was born. It's dirty, it's horrible, I don't like using it, and I try and not use it if ever I can. I'm a believer in using olanzapine, one of the new antipsychotics, which is much safer, much nicer. But these are the drugs we also use to rapidly sedate people when we need to rapidly sedate. So it tells you the sort of drugs we're using on people with dementia and delirium. We're using rapid sedating drugs. The BNF, which is our guidebook, says we should use the lowest dose, the shortest duration. And for the professionals out there, we should avoid these in Parkinson's, dementia of Lewy body, not Lewy body dementia, but in dementia Lewy body and prolonged QT. I knew that Dr. Purchase would smile at that one. Now, quality improvement. For the medics out there and people that are, there's the Sepsis 6 program that has been running for crumbs now, 15, 20 years, looking at sepsis. I spent the last 6 months building a quality improvement project that's going to go live soon at Royal Cornwall. And it's going to be based upon the Sepsis 6. The hospital are going to put a lot of money behind it because they've started to realise how important this subject is. We have meetings now every single Monday at corporate level looking at delirium alone. So it's a massive project. It's been planned for the last 6 months. It's going to run for 2 years. We're recruiting juniors and senior doctors at the moment and also nurses to audit wards, and the audits are already ongoing and started now. We've got new policies coming online from next month, and they're coming into force next month. More rigorous assessment and ongoing assessment of everyone coming through the front door. The government want us just to check people within 24 hours. We're now looking for people at week 1, week 2, week 3, week 4, because we recognise people get delirium in the hospital, not just coming into the hospital. But the government only want us to look at people coming in. They don't ever want us to look at who's in hospital and getting it. So that's where we're going. So that's what the government targets, and now we're targeting at everything. We'll have new delirium champions on every ward. New protocol will be put for the next 24 months, and that's how we embed it as best practice. And we're starting next month in the emergency department on the acute medical unit, then it's going to the surgical unit, and then it's going out to the wards as well. Am I on time? That's all I was worried about. I was panicking.